sleeping. I would like to continue to use it for that purpose instead of relying on pharmaceuticals. And when I lecture to audiences, physicians, I ask in the United States, how many of you have seen patients with cancer benefit from the use of cannabis as an antiemetic? And pretty much every hand in the audience rises. And I believe it was Melissa Etheridge who came out as saying that she could not have tolerated her adjuvant chemotherapy for breast cancer without the use of cannabis. Interestingly, however, our American Society of Clinical Oncology just had an expert panel convened last year, and they recommend FDA-approved cannabinoids, dronabinol or nabilone, to treat nausea and vomiting that is resistant to standard antiemetic therapies, and they say the evidence remains insufficient to recommend marijuana in this setting, and I think this is bad news. Actually, the ASCO Journal, which is a newspaper that reviews recent publications, a month ago had 4 articles on cannabis in the journal, and each one had a little disclosure box next to it saying that the American Society of Clinical Oncology did not necessarily agree with what was being written in this article. And I read all 4 articles, and they were so full of errors that I wrote a letter to 2 of the women I know on the editorial board, and they've asked me to write a response and write a little column called "Should Oncologists Recommend Cannabis to Patients?" And the answer to that, of course, is going to be yes. So with regards to moderate level of evidence, which was below substantial and conclusive, the only thing that we found actually similar to what my patient was writing in his email was that there does seem to be benefit to cannabis, cannabinoids, primarily nabiximols, in improving short-term sleep outcomes in individuals with sleep disturbances associated with obstructive sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. And again, it says particularly nabiximols because in their studies of the whole plant extract, they often are looking at sleep as a secondary endpoint. Limited evidence of effect. For this level of evidence, there are supportive findings from fair quality studies or mixed findings with most favoring one conclusion. A conclusion can be made, but there is significant uncertainty due to chance, bias, and confounding factors. So for limited evidence of effect, increasing appetite and decreasing weight loss associated with HIV/AIDS, and this was included both cannabis and oral cannabinoids. Improving clinician-measured multiple sclerosis spasticity, improving symptoms of Tourette syndrome, improving anxiety as assessed by a public speaking test in individuals with social anxiety disorders, and in fact, this was the largest previously published randomized placebo-controlled trial of cannabidiol in the medical literature. 24 patients with social anxiety, and they were given a public speaking test mock-up, and those who received, the 12 who received CBD were less anxious than the 12 who received placebo. And prior to the Epidiolex studies in children with epilepsy, this was the largest study of CBD. And so obviously there was no meta-analysis, but we rated that paper high enough to include this as limited evidence of effect. And as Rafi said, improving symptoms of post-traumatic stress disorder, although we all know this is correct. I mean, I say, you know, most Vietnam veterans in the United States are using cannabis, and it's clear to me that it's to treat their post-traumatic stress disorder, although clinical trials are still going on to attempt to prove that cannabis is useful. No or insufficient evidence, and I'm doing this for a reason, to show you that in the medical literature with regards to therapeutic benefits, there are a lot of things that we assume cannabis is useful for, but when you actually dive down into what's published in the medical literature, there may be no real evidence. And so for us to conclude that there was no or insufficient evidence, there are mixed findings, a single poor study, or a health endpoint has not been studied at all. no conclusion can be made because of substantial uncertainty due to chance bias and confounding factors. So cancer-associated anorexia cachexia syndrome and anorexia nervosa, we found no or insufficient evidence. Now remember, for HIV-associated, there was some limited evidence, but for cancer-associated, the evidence is not quite as strong. And one of the largest studies of cannabinoids in cancer patients was this older study reported in 2002, randomized double-blind placebo-controlled study of 469 adults with advanced cancer and weight loss, where dronabinol or progesterol, which is a progestational agent that increases weight, were compared against each other and then in combination. And you can see dronabinol was inferior to progesterol in increasing appetite as well as weight, and the combination was inferior to the progesterol alone. A smaller randomized controlled trial of dronabinol did demonstrate that dronabinol made food taste better, appetite increased, and calories were increased, but there was no difference in weight. And two recent studies were reported when I did a review of clinicaltrials.gov, which tells us of studies that are ongoing. One has been completed, the study in Mexico, and then the study of the cannabis capsules also was completed in April 2018, but as yet I did not find any data published. However, the nabilone study in Mexico recently was published in the Journal of Supportive Care in Cancer this year. This was a randomized placebo-controlled trial, 47 outpatients with non-small cell lung cancer, very frequently associated with weight loss and cachexia. At 8 weeks, those randomized to nabilone increased their caloric intake and had higher intake of carbohydrates compared to placebo, which was statistically significant. However, no increased weight. There were significant quality of life improvements in role, emotional, and social functioning, as well as improvements in pain and insomnia. So again, the data on cannabinoids in anorexia associated with cancer is not there. However, the plant itself has not been studied. And yeah, when we came across this finding every afternoon when we were meeting in Washington, we had to summarize what the findings were. And when the group heard that cannabinoids are not effective in increasing appetite, everybody said, what? Because I guess everybody went to college, so they know that you do get the munchies. But the rejoinder was that no study has actually looked at cannabis. And in fact, this may be a situation where the entourage effect is important, where you need other than just THC to actually increase appetite. So there's also no or insufficient evidence for cancer. So this is the answer to the question, the subheading, does cannabis cure cancer? In fact, we had to go outside of our charge and look at a study that was not done in humans. We found one meta-analysis that looked at 34 in vitro and or in vivo experimental studies and included one pilot study in humans. All but one study, and these are in patients with gliomas, all but one study showed that cannabinoids selectively kill tumor cells. Well, let me just take a step backward. Our friend, Rafi, and my friend Manuel Guzman from Complutense University in Madrid has a laboratory that studies the effect of cannabinoids on metabolism. And the most highly active cells in the body metabolically are the brain cells. So they would grow up mouse brain and add cannabinoids and see what happened. And they said, maybe we could do our research faster if we grew up a brain tumor. So they grew up a mouse glioma and they added their cannabinoids and everything died. So they said, oh, maybe we did something wrong, so they did it again and everything died. So they said, well, maybe it's a bad batch of cannabinoids. So they went back to the normal brain and added the cannabinoids and everything lived. So since the brain, the single most densely populated 7-transmembrane domain G protein coupled receptor in the human brain is the CB1 receptor, it maybe makes sense that cannabinoids may have an effect on brain tumors. And Manuel's lab and labs in Italy, Vincenzo Di Marzo, have looked at the effect of cannabinoids on killing glioma cells. And they find that there's direct tumor cell killing. Also, there's anti-angiogenic effects. That is, the cannabinoids decrease vascular endothelial growth factor, which allows new blood vessels to proliferate. And in addition, they find anti-migratory effects. Cannabinoids inhibit something called matrix metalloproteinase 2, which allows cancer cells to become invasive and metastasize. So there is pretty strong evidence in vitro that cannabinoids may have some effect. And actually, this evidence first came from our own National Cancer Institute in the United States in 1975, when investigators reported that delta-9 THC, delta-8 THC, and CBD all inhibited Lewis lung adenocarcinoma cell growth in vitro and in mice. But that research moved again off of our coast over across the pond to Spain and Italy predominantly. And again, cannabinoids and cannabis are antioxidant and anti-inflammatory, which are always things that I look for to help my cancer patients. So in addition to the in vitro activity, if you take mice that don't have an immune system and transplant them with human cancers, these are all the different cancer types that are inhibited by cannabis in the mice. So it seems like the answer to the question should be yes, but Petri dishes are not humans. We have immune systems and we have livers that detoxify compounds, and in fact, mice are also not people. So we know that cannabinoids induce apoptosis or programmed cell death in mouse gliomas, and I've already explained to you that in addition to direct cancer cell killing, they reduce expression of vascular endothelial growth factor, which is what a very expensive drug, bevacizumab or Avastin, does. And then they decrease the ability of the cells to become invasive and metastasize. And despite all of this, the normal brain cells are unaffected. So that's cannabinoids, usually laboratory cannabinoids, predominantly THC. What about CBD? Well, we know in colorectal cancer cell lines, CBD protects DNA from oxidative damage, increases the level of the endocannabinoids, and reduces proliferation of the anti-cancer cells. In mice, there's a chemical called azoxymethane, which if they're treated with it, it promotes the development of colon cancer. And if the animals are pre-treated with cannabidiol, this is attenuated. So there is some evidence that CBD may also have some anti-tumor activity. In fact, a friend and colleague, Sean McAllister in San Francisco, has a culture of triple-negative breast cancer cells, and he finds that they produce an increased level of a protein called an ID helix-loop helix protein. These proteins control processes related to tumor progression. When he puts CBD in culture with these triple-negative breast cancer cells, it down-regulated expression of this protein in the test tube, which led to our newspaper to put out a headline that cannabis was effective against the most aggressive form of breast cancer. And when the newspaper called me for a comment, I said, you know what? I was an AIDS doctor for many years, and I know that soap suds and gasoline kill the AIDS virus, but I wouldn't consider either of those to be effective treatments. And again, I don't think we're to the point where the number of patients who I see in my oncology clinic who are treating their cancer with highly concentrated CBD or THC really makes any sense. So the first human trial was from Manuel Guzman. Manuel, PhD, actually went to the Canary Islands and found 9 patients who had recurrent glioblastoma multiforme, the most aggressive form of brain tumor. And he dripped THC by way of a catheter into their tumor cavities, putting a catheter into the brain. I told him, Manuel, we don't treat brain tumors topically. But he found that the treatment was well tolerated. There was no effect on survival different from those patients receiving chemotherapy alone. But when he took biopsies of the brain, THC inhibited the proliferation and decreased the viability of the glioblastoma cells. And it was later demonstrated by Jahan Marsu that if you added CBD, it enhances the inhibitory effects of THC on the glioblastoma cell proliferation and survival. So an investigator here at the Hadassah Medical Center had a study that was listed in clinicaltrials.gov where he was going to look at pure CBD as a single agent for solid tumors. And a few years ago, I sent him an email asking the status of that trial. He was looking for 60 patients who had progressive disease after standard therapies, and told me through an email conversation that the study had closed after he enrolled 3 patients with glioblastoma and 1 with another malignancy and saw no response. A study that has also been completed but not published in the medical literature only as the form of a press release is a study of nabiximols, the 1-to-1 ratio of THC to CBD. 12 patients with recurrent glioblastoma sprayed nabiximols under their tongue, 9 patients sprayed placebo while they were getting the standard chemotherapy. And what they found was a statistically significant improvement with 83% of those getting the nabiximols surviving to 1 year compared to only 53% of those getting placebo. And the median survival at the time that the press release came out was 550 days in the nabiximols group compared to about a year in the placebo recipients. I've asked the company a number of times when this will be published, and they tell me that the difference in median survival continues to expand, so they're waiting for that to plateau before the article is published. Again, it's a study in only 21 patients. Oncologists are very much evidence demanding because we deal with a very serious disease and we use very potent and toxic medications. So most oncologists are not going to be jumping up and down with these results in only 21 people. Now, an area that I was always very interested in and I could never find anybody to do the work was what kind of expression of cannabinoid receptors do we find in different tumors? And the study was published 2 years ago by Ladin et al. Looking at different tumors and whether they overexpress or underexpress CB1 and CB2. And you can see that the different tumors do different things and they're associated with better or worse prognosis. There was just a study, very interesting, published in the journal Prostate, where prostate cancer cells in the test tube, when WIN, which is a synthetic cannabinoid, is added, seems to suppress replication and division of the prostate cancer cells. And if those cells are treated with a CB2 antagonist, that suppression of growth is inhibited, suggesting that this is modulated by way of the CB2 receptor. So I think this is an area that's very interesting in research, and talk about being disruptive and energetic and finding new things. I would like to see how this pans out in the future. I'm one of the editors of the National Cancer Institute Physician Data Query webpage, and every month we update this page on cannabis and cannabinoids, reviewing all the literature that's been published in the field, both for symptom management as well as for possible anti-cancer activity, again, most of that in vitro. This is the famous Siberian ice princess, which is a body that was found, estimated to be 3,000 years old, and it's reported that cannabis may have eased her symptoms. She was under an MRI scan found to be a woman in her 20s who had metastatic breast cancer with bone metastases. And around her waist she had a pouch in which were the flowers of the female plant of Cannabis sativa. And the archaeologists or anthropologists or whoever it was that make these hypotheses suggested that she was perhaps using the cannabis not only for treatment of symptoms related to her cancer, but for the cancer itself. Well, I think that is a huge leap. First of all, we don't know that everybody in this tribe was not buried with a pouch of cannabis around their waist, whether or not they had cancer. So that's the sort of leap that my patients are making, taking information from the internet and deciding that cannabis might cure cancer. Now, in Israel, I have to give you a lot of credit. In the United States, everybody said, Israel does all this work. Why don't we do this work? Israel does. So, maybe you do. So, the study that was published in the European Journal of Internal Medicine this year looked at 2,000 licensed cannabis patients in Israel and reported the symptoms that were most improved. And you can see nausea, vomiting, sleep, restlessness, anxiety, depression, itchiness, and headaches. Interestingly, pain is not there except for headaches. And very important, 1,000 patients reported on changes in their medications. 35% reported decreasing their concomitant pharmaceuticals, and of 344 patients on opioids, 36% stopped them, and 10% were able to decrease their dose. Now, in addition to symptom management, one reason that I found myself in the past writing a lot of letters for my patients to be able to access cannabis were in my breast cancer survivors. The relationship between alcohol intake and the risk of estrogen receptor positive postmenopausal breast cancer is linear, as you see here. And many of my breast cancer survivors are now back at work, and their colleagues want to go out for a drink after work. Or they come home from work and their husband comes home from work and he says, let's have a cocktail. And my patients would like to be relaxed and socially lubricated, but not undergo the potential risk of alcohol and its toxicity. And because I believe that cannabis is infinitely more healthy than alcohol, I would write these letters gratefully. When I go to the conferences of the International Cannabinoid Research Society, for example, where people are working with animal models, they often describe cannabis-induced euphoria as a side effect of treatment. It may be a side effect, but I don't think euphoria is necessarily an adverse experience, especially if you're dealing with patients who are facing cancer or other situations that put them towards the end of their life. I have a single treatment that increases appetite, decreases nausea and vomiting, relieves pain, and improves mood and sleep. And I find that to be a very powerful tool in my management of patients with cancer. Instead of writing prescriptions for 5 or 6 different medicines, which may all interact with each other, or the chemotherapy that I'm giving my patients, I can recommend one medicine. And I ask all of my cancer patients, what brings you joy? And the number of patients with cancer who say that gardening brings them joy is not insignificant. I think that if you feel that you're dying or part of you has died, the ability to bring life out of the ground is a mitzvah. And if you can grow your own medicine, that's very empowering. But what about this issue? Does cannabis inhalation lead to cancer? 23% of cancer in the United States, or 28% of cancer deaths, are related to cigarette smoking. This has been surpassed, by the way, in the United States by obesity and overweight, which account for 40% of cancer. I've been in Israel for 3 days, and I'm amazed at how much tobacco use I see. It's a little disturbing. In our country, 5 to 10% of adults smoke cigarettes. So what did we find in the National Academy's review on the effect of cannabis in cancer? We said that there is moderate evidence of no statistical association between cannabis smoking and the incidence of lung cancer. And there's moderate evidence of no statistical association between cannabis use and the incidence of head and neck cancers. And these come from reviews of a number of studies. So the evidence is strong, or moderate, if I should say, but still pretty good. No statistical association. There is limited evidence of a statistical association between current frequent or chronic cannabis smoking, and testicular cancer. Now, we had coming to present to us at this somebody that came from our National Traffic and Safety Division, because what happens to traffic accidents in states where cannabis is legal is a big issue. And he told us that there may be some increased traffic accidents in those states. But he said, but who gets into traffic accidents? Young men. And who smokes cannabis? Young men. So he says when you correct for that or adjust for that, the increase disappears. And I think the same situation is here. Who gets testicular cancer? Young men. And who smokes cannabis? Young men. So the relationship is probably the same as noticing that there's increased number of drowning deaths in the months where ice cream is overconsumed. It's true, and unrelated. So oncologists are very nervous about the interaction of any botanical with the chemotherapy that we prescribe. And again, there have been very few studies that look at the potential adverse effect of cannabis and chemotherapy, but to date, none of them have really shown any significant adverse effect. I must say that I am very concerned about CBD, because CBD is a potent inhibitor of cytochrome P450 enzymes, which are involved in the metabolism of many pharmaceuticals, including our chemotherapy agents, some of them. And I fear patients taking these highly concentrated oils of CBD to cure their cancer are maybe going to increase the toxicity of their standard chemotherapeutic agents. Now again, from Israel came an interesting retrospective study. As you know, immunotherapy is very much the rage right now, and I, as an integrative oncologist, often recommend that my patients use medicinal mushrooms during their cancer treatment, but I've chosen to tell my patients using immunotherapies not to take medicinal mushrooms, because the mushrooms are immune enhancing and the immunotherapy is immune enhancing, and I don't want them to fight. Now, interestingly, this study by Gil Barsal and his group was a retrospective observational study looking at 140 patients, 89 of whom used nivolumab, the immunotherapy itself, and 51 did the nivolumab and were using cannabis at the same time. And what they found was that those patients that used cannabis with their immunotherapy had inferior responses to the immunotherapy compared to those who just used the immunotherapy alone. Although I believe that the finding was that survival was the same. Now, oncologists in the United States, especially those that care for patients with hematologic malignancies, are always concerned about the fungal infection aspergillosis. And we reviewed all of this data in the National Academies group. And the initial case report came from my friend and colleague, Anthony Fauci, who's the head of our National Institute of Allergy and Infectious Disease, and he published this when he was a fellow way back in 1975, the first case report. And subsequently, there have been isolated case reports in patients with hematologic and solid malignancies and other immunocompromised states associating cannabis use with the development of this pulmonary fulminating fungus infection. Mainly smoked cannabis, although there was a 2015 study of a case from vaporized cannabis. I'm not sure how that could be possible. Cannabis in a series of 13 age-related cases was only implicated in 4, and I believe the best study is really a case control study of 19 patients with HIV who had positive aspergillus in their bronchoalveolar lavage, and the aspergillosis was associated with the lowest neutrophil count, the most severe immunosuppression, steroid use, and prior pneumocystis infections, and cannabis use was not associated. So I think that the fear of aspergillosis is unfounded, and I recently spoke to our group in hematologic malignancies at the University of California, San Francisco, and on the basis of this, they decided to change their recommendation The letter that they used to write for their patients said that they could not use inhaled cannabis, but on the basis of this data, they decided to change that and allow their patients to use inhaled cannabis. So oncologists, even in the august and very conservative New England Journal of Medicine, had the opportunity to respond to a case of Marilyn, a 68-year-old woman with metastatic breast cancer, seeking cannabis to alleviate her symptoms. Interestingly, both of the discussants in this case were mental health professionals as opposed to oncologists. But after the article was published, they opened it up to their blog, and they said they're surprised by the outcome of polling and comments, with 76% of all votes in favor of the use of marijuana for medicinal purposes, even though marijuana use is illegal in most countries. And a subsequent survey from WebMD, looking at 1,500 physicians in 12 specialties, over 2/3 say that cannabis is helpful, and oncologists and hematologists show the highest level of support among specialists, 82% supporting the use of medical cannabis. Interestingly, Ilana Braun from Harvard just published in the Journal of Clinical Oncology a survey of 400 oncologists that were randomly selected, 63% response rate, which is quite unusual for a cold survey. 80% of the oncologists said that they conducted discussions regarding medical cannabis. 78% of those discussions were initiated by the patient. 67% of the oncologists viewed cannabis as a helpful adjunct to standard pain management. 65% thought it was equally or more effective than standard therapy for anorexia and cachexia. 46% recommended it clinically, and only 30% felt sufficiently informed to make recommendations. I think all of us have been trained during the era of reefer madness and cannabis prohibition, and it's really important now for us to move the envelope forward and develop, as we heard this morning, good ways to teach physicians how to use cannabis, and we also need to study the plant more. And when my oncology colleagues say to me, "Gee, Donald, in these days of genomic therapies and nanotechnology, why do you continue to be interested in studying a plant?" I tell them it's to get us back to the roots of medicine. And with that, I'll say thank you for your attention. Toda rabah.